Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Iskandar. I am from UiTM Puncak Alam. Today, I want to present radiographic image evaluation of anteroposterior elbow. Firstly, we are going to look at radiographic anatomy. Second, identification of projection. Third, criteria of correct positioning. Fourth, criteria of adequate exposure factors. And lastly, image evaluation using placement method. Before evaluating any radiograph, a radiographer must have a strong understanding of the anatomy being demonstrated. This slide shows the important anatomical structures visible on AP elbow radiograph. This is olecranon. This is lateral epicondyle. This is capitulum radial joint. This is radial head. This is radial neck, radius, ulna, radial tuberosity, coronoid, medial trochlea, medial epicondyle, olecranon fossa, and humerus. Next is identification of projection. This is the projection of elbow. Elbow joint is at the center of collimation field and includes 1/4 proximal radius ulna and distal humerus and lateral tissue. This is AP because radial head and tuberosity superimpose lateral aspect of proximal ulna by 0.6 cm. In addition, the coronoid process is demonstrated and on end radial tuberosity is seen in profile. The capitulum radial joint is open with the olecranon process lying within the olecranon fossa. Furthermore, both the medial and lateral epicondyles are demonstrated in profile. Next, we are going to see the criteria of correct positioning. To determine whether an AP elbow has been positioned correctly, several image criteria must be assessed. Firstly, medial and lateral epicondyles are in profile. Secondly, radial head and tuberosity superimpose lateral aspect of proximal ulna by 0.6 cm. Third is coronoid demonstrated and on end radial tuberosity seen in profile. Next, capitulum radius joint is open. Olecranon process within olecranon fossa. For AP elbow, there are two circumstances. First is detecting elbow rotation, and second is detecting elbow flexion. One of the most important positioning assessment is evaluating elbow rotation. This can be determined by examining the degree of superimposition between the radial head, radial tuberosity, and the proximal ulna. Before detecting the rotation, we need to know what are the criteria of no rotation of elbow, which is accurate 0.6 of radial head and tuberosity superimposition. There are two types of rotation. First is internal rotation. Radial head and tuberosity superimposition more than 0.6 cm. Second is external rotation. Radial head and tuberosity superimposition less than 0.6 cm. Besides rotation, elbow flexion should also be assessed. This is done by evaluating any distortion or foreshortening of the distal humerus and proximal forearm. There are two types of elbow flexion. First is distal radius ulna elevated, which we can see distal radius ulna foreshortened. Second is humerus elevated, which is proximal humerus foreshortened. Criteria of adequate exposure factors. Adequate exposure factors are essential to produce a diagnostic quality radiograph. Therefore, both contrast and density should be evaluated carefully. For contrast and penetration, the bony cortical outline of thin and thick structures must be able to visualize, such as the outline margin of the structures must be seen. For AP elbow, the thin structures are bony cortical outline of lateral and medial epicondyles. Thick structure is bony cortical outline of olecranon. For density and detail, the bony trabecular pattern of thin structure and thick structure must be able to visualize, such as the structures must have shades of gray or color in them. For AP elbow, thin structures are bony trabecular pattern of lateral and medial epicondyles, while thick structures is bony trabecular pattern of olecranon. Next is image evaluation using placement method. What is placement? Placement is a short form for projection and positioning, alignment, collimation, exposure factors, marker, aesthetic, and name. First, we are going to evaluate projection and positioning. This is a radiograph of AP projection of elbow. Every projection identified on a radiograph must be supported with appropriate image criteria and anatomical evidence. This is elbow because the elbow joint is at the center of collimation and includes 1/4 proximal radius ulna and distal humerus. Next, this is AP because radial head and tuberosity superimpose lateral aspect of proximal ulna by 0.6 cm. In addition, the medial and lateral epicondyles of humerus are in profile. Next is positioning. Firstly, we evaluate elbow rotation. We need to evaluate radial head and tuberosity superimposition of the ulna. The humeral epicondyles are not in profile and more than 1/8 of the radial head is superimposed over the ulna. The elbow was internally rotated. How to improve this? We need to rotate the elbow externally until the humeral epicondyles are parallel with the image receptor. Next, we evaluate the elbow flexion. We need to evaluate the distortion of or foreshortening of the distal humerus and proximal ulna. The distal humerus is demonstrated without foreshortening, but the proximal forearm is severely distorted. The humerus was positioned parallel with the IR and the distal forearm was elevated. How to improve this? If possible, fully extend the elbow. If the patient is unable to extend the elbow, this is an acceptable projection of the distal humerus. A second AP projection of elbow should be taken with the forearm position parallel with the image receptor. Next, A for alignment. Alignment assessment involves evaluating the relationship between the X-ray tube, patient, and image receptor. 3 alignments will be assessed in this radiograph. After that, we are also going to discuss the centering point for this radiograph and the standard centering point for AP elbow. The first alignment assessment involves evaluating the relationship between the X-ray tube and patient. For this alignment, we are assessing the border of collimation to the central structure. The alignment between X-ray tube and patient cannot be determined because there is no evidence of collimation on all 4 borders of the film. The second alignment assessment focus on the relationship between X-ray tube and image receptor. For this alignment, we are assessing the border of collimation to the border of film. The alignment between border of collimation to the border of film cannot be determined because there is no evidence of collimation on all 4 borders of the film. The final alignment assessment evaluates the relationship between patient and the image receptor. For this alignment, we are evaluating the border of film to the central structure. The alignment between the patient and the image receptor is incorrect because the distance between the central structure to the edges of film at superior and inferior is not equal. Another important component of image evaluation is determining the centering point used for this radiograph and the standard centering point for this projection. The centering point for this radiograph cannot be determined because there is no evidence of collimation on all four borders of the film. The standard centering point for this projection should be at the mid-elbow joint, which is approximately 2 cm distal to midway of a line between epicondyles. Next is collimation. Proper collimation is important to minimize patient radiation exposure while ensuring all required anatomy is included. The standard structures that should be included in this radiograph at the superior border is 1/4 of the distal humeral. Both lateral borders should include surrounding soft tissues of the elbow. The inferior border should include 1/4 of the proximal radius ulna. There is no evidence of radiation apparatus seen on the radiograph. Next is exposure factors. For exposure factors, we are going to evaluate the contrast and density of this radiograph. The KVP used is adequate for penetration and radiographic contrast. This is because the bony cortical outline of thin structure, which are the lateral and medial epicondyles of humeral, can be seen, while the thick structure, which is olecranon, also can be seen. The MAS is adequate for detail and density. This is because the bony trabecular pattern of thin structure, which are lateral and medial epicondyles, can be seen, while the thick structure, which is olecranon, can be seen. There is no need to improve this image quality. We need to maintain the KVP and MAS. Next is marker. Marker evaluation is important because it confirms the anatomical site being examined and helps prevent identification error. There is evidence of an anatomical marker shown in the radiograph correctly placed on the left side of the body and placed appropriately, not superimposing any region of interest. Next is aesthetic. The aesthetic evaluation includes assessment of film size and the presence of any image artifacts. The film size used for this radiograph is 24 x 30 cm, which is sufficient to demonstrate all structures of interest. There is no evidence of artifact on the radiograph. Last but not least is name. Patient identification is a critical component of a radiographic image evaluation and medical legal documentation. For this radiograph, there is no evidence of patient's name and ID, date of examination, and place of examination. Conclusion: Based on the placement evaluation performed, this radiograph should be rejected for several reasons. Firstly, there is no patient name, identification number, examination date, or examination location. Secondly, the elbow demonstrates excessive internal rotation as evidenced by increased superimposition of the radial head over the proximal ulna. Finally, the alignment between the patient and image receptor is incorrect. Therefore, this radiograph is not acceptable for diagnostic purposes. This is the reference that I have used for this presentation. This concludes my radiographic image evaluation of the AP elbow. As Steve Jobs once said, innovation distinguishes between a leader and a follower. Thank you for your attention. I welcome any question or comments.